Morning, everyone. Thanks for making the time to be here, and also for anyone attending online. Appreciate your attendance. I'm personally very excited to be here to introduce my friend and colleague, Dr. Greg Broderick, who I've had the privilege of knowing for several decades now through various roles with SMSNA and also AUA. I'll cheat a bit with his background bio because I don't have that memorized, but he did his pre-medical studies at Harvard, a medical degree from our own institution, UCSF, so he's one of our homegrown talent. Internship at New Haven Hospital. Then he was telling a story yesterday how he came back to us at UCSF and did his residence here as well. So he's an alumni in multiple senses. He went on, again, a connection I have with him is that he went to UC Davis for his fellowship. I walked by his photo every day on my way to my office while I was on staff there. So it was an inspiration to see that great people have come through there before. Quality might have dropped off after he left, but anyway, I tried to follow in his shoe steps. He joined the University of Pennsylvania as assistant professor, and then in 1998, a significant year for me, which I won't disclose why, but it was, well, anyway. It was a good year for me, and in May, he joined the Mayo Clinic, Florida faculty at that time. And really since that time, I'll kind of skip over the rest of this, many accomplishments, really has set himself up as a champion, as a leader. He's been described by people I know in my society as the hardest working guy we know. And I think that's true, is that he has his fingers in many different pies. He does a lot of work for AUA and SMSNA. On a personal note, I think, Greg, you were the first person who ever personally called me and invited me to speak at SMSNA. I think you asked, oh, is this Alan Schindel? I was like, yes. So I'm Greg Broderick. Greg Broderick's calling me. It was very exciting, and I've always had a special place in my heart for you for that very reason. Wonderful advocate, great educator. He's the program director, so he has a lot of roles, both in his institution and outside. I won't continue to sing his praises, but there are so many of them. So Greg, we're really excited to have you here and very much look forward to your talk. So thank you.
So there's a quotation from Lyndon Johnson. Probably, Jack, you're the only one in the room remembers Lyndon Johnson, who once said, that was an introduction that my father would love, but only my mother would believe. So thank you very much for those kind words. And yes, it is great to be back here. The campus has changed dramatically just walking in. I will say to you that I sat in these chairs last time probably in 1989. So that kind of dates me there. This past year, I was honored to receive from the AUA the Gold-Headed Cane Award. And that doesn't mean I have a bad knee, because I do have a bad knee. It just means I've dedicated a lot of service to education. So Lindsay, just through Education Shield alone, we think at Mayo 3 shields: research, education, and clinical care. The AUA will recognize you hopefully one day as they recognize me. This was from the Dudish Museum, and I don't know how many of you have visited the AUA, but every year they set up a display from the official AUA museum. And this one was set up by Bud Burnett to recognize the contribution of African-American urologists to urology. So Bud asked me to send in a few pictures. And so the picture I chose was from when I was a resident here, circa 1989. Current picture, and there's my lovely wife and daughter. But he also asked me to say a few words about mentorship. Now, I know as a program director that you're assigned mentors these days in order to help you through the process of your education. That wasn't the way it was when I trained. So I said quite simply, I owe my skills and urologic knowledge and personal growth to the expertise and wisdom of numerous mentors. They weren't assigned to me and given a schedule for timely feedback. They were individuals I sought out. They were individuals of generous character and great enthusiasm for urology. I let them know that they were valuable, and in turn, they have shared, they have guided, and they have supported my career. So I said very much thank you to Jack McAninch, Tom Liu, Ira Charlip, Alan Ween, and Martha Terrace. So as you go through your career, you will find people with similar interests, acknowledge their talent, their skills, and I think that you will naturally develop either collegial relationships like I have with Alan, or you'll develop mentorships that you will value forever. And I don't know if you guys still wear the patch. Do you still wear the patch and the ice cream suit with the short white coats and the white pants? No. Oh man. Oh man. Let me come back and bring some style to you guys. So I have only one disclosure, or maybe two. I am an investigator for endopharmaceuticals. I will mention a product that they make. Also, this lecture was not created by any AI system, ChatGPT or DeepSeek or any of those things. So I'm just going to go through with you a little bit today the clinical management of Peyronie's disease. And I approach this topic with great trepidation, knowing that there are fantastic surgeons here with Alan and Ben doing the surgery and with Tom still doing the active research. He was blowing my mind as he was driving me back to the hotel last night on how active his research is. But this is the clinical workup and management. So we all understand that it's an acquired abnormality characterized by fibrosis of the tunica albuginea. And it can be accompanied by pain, deformity, erectile dysfunction, penile shortening, and psychologic distress. The most contemporary guidelines have yet to be published. I was honored to be part of this panel that met in the summer of 2024. So I'm going to share with you some of the pre-publication guidance that comes out of that. So we presume this is a wound healing disorder, that the two lamina of the tunica albuginea, which Tom nicely described in the New England Journal of Medicine article back in the early 90s, longitudinal layer as opposed to the circular layer, that there's trauma between those two layers, repetitive trauma. There can be small bleeds between those two layers, and that's what sets up the typical Peyronie's plaque. I'm sorry, somehow I've switched back to a laptop for the guidance of this. There we go. All right, so what I've learned in my own practice is that PD is clearly a progressive disorder. This is a photograph of the same patient, July, August, and November. Very dramatic changes in Peyronie's disease. It's led a lot of us to acknowledge that there can be an early phase and a late phase to the disease, but it clearly is progressive. In my practice also, I've made a study of evaluating and asking patients about Dupuytren's. Do you guys ask about Dupuytren's when you see a Peyronie's patient? I think it's very important because there's this acquired form and then there's this inherited form. And this is an MRI of a hand in this projection showing the Dupuytren's contractures. One of my own patients, I use something called the Mayo cell phone app. I don't know how you guys document patient trauma or patient presentations, but essentially it's an app that I can take a picture on my phone and it automatically uploads the patient's photograph to their Epic chart. So you do it with their permission. And you can see he has a very severe Dupuytren's contracture and also a very atypical presentation of Peyronie's disease. So it's yet to be determined whether these atypical ventral bends, lateral bends are more common in Dupuytren's contracture, but that's been my clinical impression that you do see that. We commonly state that the likelihood of Peyronie's occurring is about 9%. The prevalence is about 9%, but in some population studies, it's as high as 19%. So it is a disease process of sexually active men. You will likely not encounter it in ED unless you're putting in a penile prosthesis and discover the Peyronie's disease, because as men get older, they don't get nocturnal or morning erections. So I went over the presentations a little bit. You can have dorsal curvature, you can have ventral curvature, you can have lateral curvature. It's always important to try and parse out the ED versus the PD. And the way I do that in the office is just to ask the patient, if the erection were straight, would you be happy with your sex life? And then they'll go to you, I'm having some difficulty maintaining erections. So that takes you down a different pathway for evaluation. The AUA guidelines put great emphasis on doing an in-office intracavernous injection of alprostadil or papaverine or Bimix. And I have put great emphasis in the use of Doppler ultrasound, especially in patients that you're thinking about doing surgery. So I want to make a case for that. The current guidelines say that the assessment of PD should be based on a digital photograph of an erect penis following an in-office challenge or a home photograph. They also emphasize the utility of in-office testing, as our AUA guidelines did. So using that's kind of gone green on us. I don't know why, but I have the Doppler in my office and I was taught this technique by the man himself, by Tom Liu. At the time, the machines were as big as this table here and cost about $300,000. The machines now are laptop size. I'm sure you've seen them all over the operating rooms because our anesthesiologists use them to guide them, placing IV lines and central lines. And you can get it for less than $30,000. So it's a very useful tool in the office. So it allows you to differentiate vasculogenic from psychogenic, which is essential in our work. It allows you to evaluate cavernous arterial inflow and veno-occlusion, and to identify plaques and to grade those plaques in terms of their severity. Important and Devine, and I had a chance many, many years ago to meet Dr. Devine at the NIH in 1992. They described the classic Peyronie's plaque occurring on the dorsum at the top of the septum. But we now know from ultrasound and histologic studies that the disease process can really be mercurial. It can present in the septum, it can present circumferentially in the tunica albuginea, and the ultrasound allows you to characterize what your patient has going on. So this is a quick story. A 61-year-old complaining of a left bend for 12 months, no Dupuytren's contractures, remote history of coital trauma, uses PDE5s intermittently, and has palpable indurations. That's the essence of the history that you want to be able to get from every patient you see. So the evaluation in the office showed that he was vascular normal, and as a matter of fact, so normal that he required alpha adrenergic reversal. And I reverse all patients at 1 hour. Don't let them leave the office. I tell them that the erection is the property of the Mayo Clinic, and they're not allowed to go out into the waiting room or leave the building. So I reverse all erections early, and it usually is easily accomplished with 200 micrograms of phenylephrine. I don't necessarily measure blood pressure if all I'm doing is giving 200 micrograms of phenylephrine. If you have to give subsequent shots, you should monitor blood pressure. So he had an hourglass deformity, and I think you can see here that the ultrasound nicely shows this circumferential tunica abnormality. Guidelines. So our guidelines say that we shouldn't be using ESWL. We shouldn't be using shockwave for this. We shouldn't be using injections of PRP. Those were reaffirmed in 2024. So it's an active inflammatory disease. It's a progressive disorder. And there is no convincing evidence in the literature currently that platelet-rich therapy or the injection of stem cells actually can treat PD. As a matter of fact, there are a couple of rat models where PRP is actually injected to cause a lesion in the penis. What do I do in the early acute phase? And forgive me if I'm a little crude here, but my nurses call this diclofenac. I use it so often. So I have the patient apply a fingernail amount directly to the Peyronie's plaque if they're in that phase where erections are giving them pain. I will also have them start doing some modeling. And modeling obviously has to be with a morning or a nocturnal erection. But I found this very effective, and I've not found anything else more effective. For years, we used pentoxifillin because Tom had done some research on that, but that's poorly GI tolerated by a lot of patients. This is easily tolerated, and it gets them through that inflammatory phase. The one FDA-approved product is obviously the Clostridium collagenase histolyticum, the Xiaflex. It's indicated, and your notes must say this, for a palpable nodule, a curve greater than 30 degrees. It's a very expensive medicine, and if your notes don't say that, you probably won't get approved for it. Now, the clinical trials gave these shots in pairs, separated by 3 days, 72 hours. And like everything else, if you ask the people involved with the clinical trial why they chose 72 hours, they just said, I don't know, it seemed like a reasonable thing to do. I once asked the founders of BCG, who was a Canadian physician, why do you do a six-pack? Why were you doing that? He goes, well, it came as 6 things in a carton, so we just started doing that. So a lot of things in medicine haven't been all that well thought out pharmacologically. What's very difficult for patients is to come in every 3 days. The other thing I found is that 30–40% of patients will have a bad hematoma from the first shot. So the second shot, you're just injecting mush. You're not necessarily going into the plaque. So making scheduling easier, I put those shots a week apart. Xiaflex is no longer available in Europe, but there's a wonderful surgeon by the name of Sir David Ralph. Patients would pay cash for the Xiaflex, so he would give 4 shots, 1 shot a month, and he had the same efficacy and the same results as the 8 paired shots in the North American trials. So as I said, I document the home photographs, and every 6 weeks, I document the improvement. And the improvements are mild. I mean, this is not going to restore the length they've lost. It will reduce the curvature by 30–35%. And in some cases, it'll take you down from 60 to 45. Then you can easily plicate at 45, whereas 60, you'd have a lot of difficulty plicating. So who are the best candidates? The dorsal bends, dorsolateral bends, solitary plaque, easily palpable, and curvature less than 60 degrees. If it's more than 60, remember, you're only going to get 30% improvement. So you're going to frustrate that patient. Now, the studies never looked at ventral bending. Studies never looked at lateral bending. So you won't find that as an indication when you're reading about the drug. It is being used off-label in both those conditions. I'm going to talk to you a little bit about why I don't use it in lateral bends or in ventral bends. One of the things that I did with Endo was recently relook at their study data to try and understand this acute inflammatory phase. The only thing that marks the acute inflammatory phase is the presence of pain when you deeply palpate the nodule or when the patient has an erection. So we looked at those patients that describe pain in either of those two scenarios, who then receive Xiaflex, to see if there was any difference in the response, and there really wasn't. So it doesn't matter that you're in that early acute inflammatory phase. As it turns out, Xiaflex can be administered at that time. And I'm thinking that if it is a progressive thing and you administer the Xiaflex early, perhaps you're impeding or you're changing the natural history of that process. So I'm not intimidated by patients who say they still have pain. The other thing we learned is that traction does work. That harness with the big weighted ball on it, that's that's San Francisco, right? So men have understood this and women have understood this for a long time. You can put an earring in the ear and you can increase its weight or its size. The ear has collagen. It will stretch and adapt, and eventually you can get a bigger earring in. Well, same thing with penis. If you put it on some stretch, you can get more length. So tools have been developed. The one I've shown here is the Restorex device, developed by Landon Tross at the Mayo Clinic. It bends in the opposite direction. The other tool that is quite useful, though, is just one that puts the patient on linear traction. So I do use these as an adjunct in therapy. And the current new guidelines will say that rehabilitative programs can include penile injections to produce an erection or daily pharmacotherapy to keep the erections going, but also the use of rehabilitation with traction. So this is the big bane of Xiaflex. And if you read that literature, you're looking at complications of reported hematomas from 0.5% to about 13%. And some of those are actually associated with true fractures. So here are two different patients. They both come in with a hematoma. On the left, you see a hematoma that's 72 hours after that first injection, which is why I stretch out those treatments to a week apart. If my nurse examines the patient first and sees this, he'll come out to me and say, hey, Dr. B, you want to take a look at this? I'm not quite sure we should inject today. And that's true. That patient should not be injected while that hematoma is there. The second one is the difficult one. This is a hematoma following sexual activity 3 weeks after Xiaflex, and the patient heard a pop. So in the old world, this is a fracture, and this is a fracture that needs to be attended to immediately. We've learned, though, since the institution of Xiaflex, that these microfractures are actually very common, and you should probably stay away from dissecting them. Because if you think about it, they're occurring on the dorsal neurovascular bundle. The typical fracture is going to be near the base of the penis. The suspensory ligament holds the penis straight. The fractures will be lateral blowouts, either right or left. That's where the typical fracture is. But these are right underneath the neurovascular bundle. So you're dissecting through that hematoma, trying to find the injury through the neurovascular bundle. You're more than likely going to damage that patient more. Also, if you look at the Xiaflex literature for Dupuytren's, what the orthopedic surgeons do is actually crack the plaque in the office. You can watch that video on YouTube. It is unbelievable. So this is probably somewhat therapeutic when these patients have this problem, and it should not result in a dissection, in my experience. So this patient had 3 cycles of Xiaflex, 6 injections. He presents for injection number 7. He complains of a firm lump on the penis that appeared since his last injection. He was awakened with a spontaneous erection and heard a pop. So I used to laugh at that when patients would say they woke up with an erection and had a penile fracture. But in the Xiaflex world, it's a real thing. Okay, usually they're trying to disclose that they were with somebody other than their stable partner when they had the fracture. So they'll tell you that I rolled over in bed and I had a pop. Okay, so this patient developed a big bruise with a spontaneous nocturnal erection. So I suspended the Xiaflex and followed him up 8 weeks afterwards. And he'd had resolution of the hematoma, and he'd actually had improvement of straightening to less than 30 degrees. So how do you evaluate that? If you can get an MRI, that's the gold standard. You can also do a CT with IV contrast to demonstrate the size of the fracture and to help you determine whether you're going to fix it. And as I mentioned, Landon Trost, a legend in his own time, a very young man who started out at Mayo Clinic and is now in independent practice. He looked at patients that reported these spontaneous pops to see how they did. And as a matter of fact, if you had one of those spontaneous pops, you actually had a median improvement equivalent to somebody who didn't have that. Okay, so it doesn't hurt to watch it. And as I said, the MRI is the gold standard. I think you can see the T2 weighted imaging there. The bladder is fluid is bright in the bladder on that. And then you can see the little disruption on the dorsal surface. You can see the disruption in the black line of the tunica albuginea there. One of Tom's Lou's drawings from that New England Journal of Medicine article, and this is why I don't do lateral Peyronie's disease. The thickest levels of the tunica albuginea dorsally, where the longitudinal and circular layers meet, and also ventrally parallel to the urethra. The thinnest layers are laterally. And I believe, and this study kind of confirms that what you get is a real weakening of the tunica and what looks like a hernia when you're doing lateral Peyronie's disease. So you have to be cognizant of this, that you're going to weaken that tunica, and that area may just be too thin to receive the Xiaflex. So what are the surgical options for the Peyronie's disease? What do our guidelines tell you? Well, when that curvature is less than 60 degrees and the patient has reasonable length, it is reasonable to go ahead and plicate. If it's greater than 60 degrees, or there's something called an hourglass deformity, and the patients will tell you this, I get a hinge and then the penis flops, and it's difficult to penetrate, or it's difficult to enjoy certain sexual positions. Those are candidates for plaque incision or excision and grafting. Now, Tom popularized this many years ago, the 16-dot plication. How many of you guys have assisted on a 16-dot plication? There you go. It's a great operation. It was an intuitive operation. Prior to that, everything was based on the pediatric literature, where we would excise small amounts of plaque and put things together. And if you work with Dr. Baskin, he probably can tell you the history of that. But the one thing that I learned, and I learned this the hard way, is that if it's a ventral bend, simply strip out the deep dorsal vein. It makes a nice furrow, and you can lay in a single row of plicating sutures without potentially damaging the lateral neurovascular bundle. Okay, so if it's a ventral bend, strip out the deep dorsal vein. It takes you all of 10 minutes. It's an easy procedure, and you can lay in a single row. The other thing I've learned over time is that when you plicate, you narrow. So, and you can just imagine that. I mean, if I tighten my plant leg on one side to neutralize a bend, at that spot, it's going to be a little bit narrower. So I've taken in the last 4 or 5 years to using onlay grafts. And the one I've had the most success with is a grafting material that was designed for traumatic brain injuries to replace the dura. It's called Lioplant. So here you can see I'm fixing a lateral bend, single row of plicating sutures. I don't use the pharmacologic erection because I'd like to bring the erection down and put it back up when I put my stitches in. So I use injectable saline with a tourniquet. But either way is very reasonable. So here you see the plicating sutures are in place, the tourniquet's in place, the erection's pumped up, it's nice and straight, but I've narrowed the patient. And also I've left a bunch of knots there that the patient's gonna feel. So I lay the Lioplant strip over that and sew it in place to the superficial bucks with some fluorochromic. This patient had a ventrolateral plication for a dorsal bend, and you can see that the narrowing is going to be at that area of plication, and I've simply laid the Lioplant on top of that almost circumferentially. And this is another one where I laid out 2 strips, and you can see in the photograph, the very first photograph, the plicating sutures are in, and I think you can appreciate that there is some narrowing there, right? So the impression the patient is going to get is what he's looking down at from that very last photograph. That's the 2 strips of Lioplant on top of the penis. So it gives a very good result. It doesn't increase the time of surgery that much, and the patients are really appreciative. If the penis, you can't make the penis longer, at least it has a substantial girth and appearance. And you know, there are a lot of men that will undergo injections just to make the penis look bigger. So this is a valuable and easy tool if you're doing Peyronie's disease. So there's no evidence that any one surgical approach is better than others. I told you that my favorite is the 16-dot plication. But with plication, you can correct curvature with a low risk of de novo ED because you're not cutting into the tunica. And with ventral plication, for dorsal curves, there's absolutely no risk of numbness whatsoever. So plaque incision versus plaque excision and grafting. There are a number of tissues that have been reported of use. All of the guidelines say that you should no longer use artificial material, that you should use a xenograft or a human graft. I have extensive experience using the Surgicyst versus the Tutoplast. I find that the Tutoplast contracts less than the Surgicyst, so I've largely switched to that. There's also the possibility of using Tacosil as an onlay graft, and I'll show you how you might use that. So there are various steps here, and this you will not likely do unless you do a fellowship, because some of this is really nerve-wracking surgery. Mobilization of the neurovascular bundle is very, very difficult. It's not easy surgery, but degloving, artificial erection, mark the site of greatest curvature, make some measurements, and I'll show you how to do that. You excise the deep dorsal vein, and I'll show you why I do that. And then you mobilize the dorsal neurovascular bundles. So Paolo Egidio, and I don't know if you guys are familiar with any of his writings, but he's a South American Brazilian physician, brilliant physician. He spent some time during his residency with me in the early 90s. Paolo has written beautifully, and he shows here the description of mobilization of the neurovascular bundle that is most popular. So you can see you begin at 3 o'clock and you end up at 9 o'clock and you mobilize the whole neurovascular bundle. I found that quite challenging. So over the years, I developed a strategy of first stripping out the deep dorsal vein. Then you work from 9 o'clock to 3 o'clock to the 12 o'clock position. It's usually no longer than a mosquito. It's a very easy dissection. You do that proximally and distally, you get a couple of vessel loops in there, and then you can dissect the neurovascular bundles up individually rather than trying to go circumferentially. The other thing you'll notice that when you take out that deep dorsal vein, that there's very often multiple emissary veins going into the tunica albuginea right through the plaque. There has been some writing that the venous leak is more common in Peyronie's disease. I don't know if that's exactly true, but you will find a number of emissary veins. So here are those steps. The artificial erection is given. I've marked out where the angulation is the greatest. The other thing I've learned to do, and this is also a hard-fought lesson, measure the circumference, corpus spongiosum edge to spongiosum edge in the full erection, because it's easy to figure out how long your graft has to be. It's not easy to figure out that radial dimension. So measure the normal part of the penis. And I will show you in another image that I square off the corners, because when you open this up, it doesn't come out square. So I've squared off the corners. I've measured the length of the graft. I already know the radial measurement of the graft because I measured that with the artificial erection. And when you lay it in, you get these two bulges on either side of the neurovascular bundle. That's exactly how it should look. So squaring the corners. Again, I used one of Paolo Egidio's diagrams there, showing the typical H incision that is described for plaque incision. And what that ends up with are these apices on all four corners. And I found that the disease process tends to recreate itself, meaning even though you sew the patch in there, things will close down. And I've had patients come back with a recurrence when I did that alone. Now I simply square off the corners, and it's easy for the residents to go ahead and sew this in place. It's also easier for them because you've got the neurovascular bundle up and to elevate that neurovascular bundle as they're going around. So I found it takes a little bit more time, but it's actually well worth it in terms of a step. Now, if you can't cut around it, you got to cut through it. If you can't cut through it, you got to cut around it. And this is calcium. And I know Marshall has done some work in this area. I've done some work in this area using calcium scoring, CT calcium scoring, and using dual energy CT scans. And you can see the CT scan nicely replicates where this disease process has become calcified. You see the H&E image there, and you see the dual energy CT. So progression to bone formation, we think, occurs in about 1 in 5 men. Some men actually present with bone, and you can palpate that. and they're not good candidates for Xiaflex. They don't respond. So calcified PD is a contraindication for medical management with intralesional Clostridium histolyticum, and it does require extensive surgery. And I use the CT imaging as part of that staging. So again, there's the adage: if you can't cut through it, you must cut around it. And sometimes these plaques can be very, very extensive, as you see in the CT imaging on the left, and then the raw specimen in the operating room. Again, another video. I apologize, that one's not projecting well. But the classic Peyronie's disease is like a T-bone, starting on the dorsal surface and then can go down through the septum. And one of the risks you have of removing that is that the cavernous arteries are parallel to that. So you have to be very careful about how much dissection you do. And I describe it to the residents as sometimes you're just taking the roof off the house and you're not taking the eaves off. You're not going deep into that tissue, because the literature clearly shows that a lot of men that have these big commando procedures end up with ED. Well, I think you can damage the vascular architecture. So I shy away from going into the septum. And this is a patient that I've got coming up very soon. He's got a 4-centimeter long calcium plaque, and you can see that it goes circumferentially. So I know I'm going to have to patch him. And the conversation I had with him and his wife is, we really have to decide how strong your erections are now. Because in my experience, when I have to remove that much tissue, there's a 20–30% chance you're going to come back in a year or two and say, hey, doc, my erections are straight, but they're not strong anymore. So you really have to consider the placement of the penile prosthesis in some of these patients who need extensive dissection. So Paolo makes it look easy in his diagrams, but unfortunately it's not. Injury to the neurovascular bundle will cause gland necrosis, and you have to be aware of that. So junior resident, raise your hands. All right, so the blood flow to the gland is from the dorsal neurovascular bundle. Where else is it from? Corpus spongiosum, right? Okay, so gland necrosis there suggests that you've already started operating on somebody who is a vasculopath, because even if you damage the neurovascular bundle, you should still have flow through the corpus spongiosum. But you don't know if somebody's a vasculopath unless you study them, or unless they have bad diabetes. And I can remember vividly from my experience at this institution, where we used to put in a lot of semi-rigid rods in diabetics, coming and seeing this the next morning. It's a disaster. Okay? That's dry gangrene. So postoperative complications: de novo ED, glands hyposthesia, glands necrosis, palpable and comfortable sutures, bulging or ballooning of the graft, indentations and deformity, and residual curvature. So ED can be found in up to 20% of patients. If you identify it preoperatively, the guidelines, all of them say you should talk to the patient about the placement of the penile prosthesis. Doesn't matter which guideline you're looking at. A great contributor in this field has been Steve Wilson, who described the manual modeling of the penis. How many of you have seen this in the operating room, residents modeling? It works very effectively so long as that bend is 45 degrees or less. You may need to do some adjunctive maneuvers if it's more than that. But this is one of my patients who didn't even require manual modeling. Just the Titan coloplast, which has good tensile rigidity, straightened him out quite effectively in the operating room. The other advice that I give to patients is, even if you're not sexually active and you have some residual bend with your prosthesis, pump it up 3 times a week before you get in the shower and work it against the bend in the shower. And you can see remarkable straightening post-operatively because the prosthesis acts like a tissue expander. So modeling, the one difference or change I've made to the classic description is, don't close the corporotomies when you do this. Leave them open. They'll serve as a pop-off valve. There have been reports that the prosthesis herniates through the glands, and you'll see it tear through the meatus, or that it goes proximally when you're modeling. But if the corporotomies are open, it's 2 things. It's a pop-off valve, and you can see it bulging there as you're modeling. But also, if you need to make an adjunctive maneuver, it's nice to have that corporotomy open. And I'll try to explain why that is. So residual curvature, not responsive to modeling. You can incise, you can lay Tachyseal in. It's going to be a longer surgery, okay? You've got to mobilize the neurovascular bundle and do all that you would in a standard Peyronie's disease. Now, here are the 2 kits, current kits for Boston Scientific and Coloplast. And the very useful tool is the spatula. One of the things that increases the risk of prosthetic infection is the duration of the surgery and how many times you put that in and have to take that implant out because you're making corrections. You're adding an RTE because you mismeasured, or you're doing a Peyronie's surgery. So that is associated with increased infection. What I've done is I've left the corporotomies open. I inflate, I do the metal modeling, and if I still need to do relaxing incisions or plicating incisions, I'll take that spatula tool and run it out parallel to the prosthesis, grasp it so that it's between the prosthesis and the tunica albuginea, and then either do the sewing or the incising that way. So it's a very neat trick for not having to pull that implant out, which not only increases your time, but does increase infection risk. Paolo has further described these multiple relaxing incisions, and very few North American physicians are doing this, but this is why people fly to Brazil to have his operation, because he touts that he can make the penis longer. I've seen some disastrous complications from this, so I don't advise it. I do advise if you have a lateral bend that your prosthesis is not correcting, you use that technique I talked about, slide in the spatula tool and make simple tiger stripes through the side, and then inflate and see if those tiger stripes straighten out the penis. But he goes very excessively in terms, and you can see, of the multiple incisions he makes. He also describes something called the sliding technique, where you actually separate the proximal and distal corporal bodies. Please don't do that. Those are the ones that I have seen the most complications in terms of urethral necrosis and glans necrosis. So adjunctive lengthening techniques are reasonable. The new guidelines will say that, but they should be left to the hands of an expert, and really seriously consider before you listen to the patient who says, oh, I need to be longer, because sometimes the enemy of good is trying to make something better. Detailed consent with all of the complications that can occur. Use your template in Epic or whatever you use, but make sure that the patient goes home and reads those complications in addition to hearing them from your mouth. Reserve your grafting for patients who have hemorrhaging or who have significant shortening, and obviously penile prosthesis for men who have ED. A reference to one of my recent papers about imaging of Peyronie's disease, which I think is a great niche if you're going to do this business. Have a Doppler in your office. It's easy to evaluate men who come in and say, I failed a PDE5 inhibitor. Well, why did you fail? Is it severe arterial insufficiency? Is it venous leak, or is it psychologic? A lot of patients want that answer, right? Just like you go to the cardiologist and you say, I have chest pain. He doesn't prescribe medicine, he puts you on a treadmill. He does some studies to evaluate why you have it. So I use it extensively for men who fail PDE5 inhibitors, and it's the gold standard in the management of Peyronie's disease before surgery. So I think we have some time for some questions. Okay, thank you. The first question is from Professor Liu.
Great. We are so proud that you have done so much over the years. Now you're world famous, and congratulations for your AUA award. Just for the reason, the Greg mentioned is actually something that you really have to learn, because a lot of time is quite often you get complications, then you get better, right? That's what happened to you. Why you become a good surgeon? Ask Dr. Stoller, right? So again, we're very proud that you have done so well, and thank you very much for coming back to educate us. Just for the reason, a few things, I just comment on what you just did. So as you know, I have done quite a few of this stuff, surgery-wise and Peyronie's. We have done about more than 11,000 injections. So we know a little bit. Now I tell you why my trick. I don't just do the bandage or do whatever the first day. I actually ask the patient to squeeze the penis 10 minutes, 4 times a day for 3 days. And I tell you why you like to have a 3 days interval before you do the second injection. If you do the second day, usually it will be swollen. But when I do this, I don't have any problem. You know, when I do it, either I do it on Tuesday and Friday. By the time they come back on Friday, very rarely to see any hematoma or any edema. So this is very effective. I call it a chuck the chicken technique. I can tell you, but the key is that I ask the patient to do it 4 times a day for 3 days.
Yeah.
Because quite often it's the second day or the third day that becomes so swollen.
Right.
But when we do this, really, it works out very well. Yeah. I would say it's very rarely to see a hematoma nowadays. Yeah. So that's one thing that you can try it. In terms of the surgery, you know that I'm a simple guy. I always do the simple things, right? So a couple of things, what you just mentioned there, I had some modifications. For example, penile prosthesis. I put the plication stitches on first before the prosthesis and you don't tie it. So you know that quite often after dilation, the curve is already much less when you put a prosthesis. And the reason is that Peyronie's disease actually also involve, you mentioned that septum and the intracavernosal strut. So when you put your dilation, you break those connections. That's why the penis gets straighter already, even before even without any manipulation. Now for the calcified plaque, as you know, we actually like to do for the tunica sparing excision of the calcified plaque. And the trick is you go from the side. You don't go top. You don't go through the 12 o'clock position. If you go from the side, you can get out the entire calcified plaque without damaging the tunica because you can suture it on the normal area instead of the plaque. So there's no excision of the tunica. And so you may want to try that. With that technique, you don't have to worry about impotence. So that's my experience. So we call it the tunica sparing excision of the calcified plaque. And for I like you put that what called Lyle plan. So what we do is that we actually do a extra tunica tutopress for the hourglass. And it's a good procedure because you don't get inside, you don't have to worry about impotence, you don't have to worry about neurovascular damage because you only put it just basically under the dermis, and you put a few stitches to fix it so they don't move. And the satisfaction is very, very good. People usually like that, because as you mentioned, you make the penis thicker. So anyway, just a few comments, simplify the procedure. And again, thank you very much for coming back.
Thank you, Tom. So when I started my lab at Penn, because I had a lab for the first 10 years of my practice, Tom had introduced me to the benefits of Taiwanese surgeons, all of whom had to acquire a PhD. So I had many come through, and they invited me to come back and hear their thesis. This is from the Taiwanese General Veterans Hospital, the largest hospital in Taiwan. So I wear it proudly, and those were great years for me. And working with those Taiwanese surgeons has kind of led to kind of an international collaboration. So I didn't show it, but Tom is absolutely right. And I describe it to the patients this way: when you have lateral deformities, imagine the spokes on a bicycle wheel. They're all the same length, which is why the wheel is round. But if the disease process gets to some of those spokes, they're going to be shorter than others. So those spokes will expand, but you will have a notch on the side where they're not expanding. And you can actually see those microcalcifications on ultrasound if you look for those. Now, the classic teaching when you put in a penile implant is that you use that furlough tool in a virgin case and you don't dilate distally. Well, that's nice because it leaves a beautiful cushion of smooth muscle around the implant. But in a Peyronie's case, if you don't dilate distally, you're not breaking up those pillars. So you'll actually feel those as you're dilating distally. So I think that's a very important distinction between a IPP for erectile dysfunction as opposed to an IPP for Peyronie's disease. You want to dilate fully. There are other clinicians that have actually stuck a hook blade into the corporotomy and scratched it along the undersurface where the plaque is. I think that's a little aggressive, but I do dilate all of the Peyronie's patients. I haven't tried to choke the chicken, but I may try to choke the chicken. I use typically a 1-inch Curlex, and I wrap the penis after I do the Xiaflex, and I give him another one to go home with and ask him to rewrap if it falls off in 24 hours. But as always, sage advice. Ben? I can repeat it, Ben, if you just want to shout it out.
you've been NIH funded. You're a board, the AUA trustee, AUA board, excuse me, American Board of Urology trustee. You've really done everything. And as one of our graduates from this department, we're all just incredibly proud and look to you as someone who's really done it. I'm just wondering if you could share what have been some of your motivations as you've gone through your career and you continue to contribute at the highest levels for our residents. What are some of the things that have motivated you through the years that continue to kind of get you excited about what you do?
So, urology is fun. You talk to any of your other residents that are doing any surgical specialty, and they won't describe their day as fun, right? And that's what I discovered. And I came to it, not the easy way, the hard way. I graduated here. There was a fellow by the name of Paul Ebert, who was the chair of surgery. He was a thoracic surgeon, and everybody in the 80s wanted to be a CT surgeon. So he got me a spot at Yale, and I was going to be a CT surgeon. And I was doing my internship, and back in the day before the protected duty hours, it was cold and it was dark most of the winter. I would come out with never smoked, with a lighter and my key, and I would heat the key to put in my lock because the locks would freeze in the morning. So you're doing this at 4 o'clock in the morning, and you're probably not getting home till 9 o'clock that same night. So I'm in the middle of my internship doing this. And, we cross-covered services then. I don't know if you have a lot of cross-coverage anymore, but it was tough because on Sundays, you might admit 10 patients for Monday surgery, orthopedics, urology, CT surgery, be running all over the place. And then on Monday morning, you got to scrub with on some of those cases. And the happiest people were always the urologists. Even the CT surgeons who were like the gods of surgery, they weren't very happy people doing what they were doing. So I said, wow, this is interesting. And it was during the Christmas time of year, I got an overhead page when I was at Yale, and they said, there's a doctor waiting to talk to you. So I figured it was somebody that needed advice or was sending a patient in for me because I was the intern. And it was Jack McAninch. And I recognized his voice immediately. He goes, Greg, is that you? I said, Jack, Dr. McAninch, is that you? He goes, yeah, Greg, we got a little issue here at UCSF. We had one of the guys drop out. I talked to the faculty. They all remembered you. You want to come on back? And that was my career, okay? That was my career. So, as I said, choose your mentors wisely. I know Lindsay's going to assign you somebody, but that doesn't mean you have to stick with that person. You're going to work with them. You're going to find them interesting, and then you're going to want to model what they do. You want to model best practices, right? I never get angry at a resident who says to me when he does something or she does something that I didn't teach them. I ask them, where did you learn that? Oh, Dr. Eigel taught me that. So you realize that they work with multiple surgeons throughout their residency, and they're taking the best part of every one of those things that they see, and they're making their own surgical style out of it. Just like you heard Tom and I, interchanging there. I'm going to take some of those things he said to heart and try those things. So it's a fun specialty. You will enjoy it whether you go into private practice or not. I think Peter's probably online, but Peter voted me to be the resident most likely to go into private practice. So don't always listen to them when they give you life direction, but
We see you up there.
Enjoy what you do, whether you take that to the private practice arena. You're going to graduate this program with skills that are going to make you the envy of your community. You want to make those people that taught you proud by continuing that excellence, by seeking out those best outcomes. Take the opportunity, even if you're not involved with basic science, to write while you're a resident. Because if you go into private practice, your patients are going to come in and go, I looked you up, and they'll be looking you up from when you were a resident. Okay. I think that's so important. You can have a great website, flashy and stuff like that. But if you have a background and patients can look and see what you've done and that you have an interest in science, you have an interest in surgical outcomes, that's important. Going the other way, though, getting involved with an academic career is not easy, right? You'll spend a lot of time sitting at your desk at 7 o'clock at night when the cleaning people are knocking on your door because you've got your day job, which is taking care of your patients. And then you've got your residency job, which is paperwork unbelievable. And then you've got this academic job where you are trying to write. Alan Ween told me when I first started, don't turn down any offers. Meaning if you get asked to travel and you've got a long way to go, you accept that offer because you acknowledge that's going to be helpful in that career. So you don't turn down offers early on. I was very lucky because the Alan was probably the best chairman I could have as a junior faculty because he was so world renowned in everything. He'd get all these opportunities to write and speak. And he would knock on my door and go, Greg, you know more about this than I do here. Right? And so you take that opportunity and you run with it. But basically, you're here for a specific reason. You found urology interesting. You don't find residents dropping out of urology anymore. You just don't find that, okay? Back in the day, people would drop out during their internships because they realized this is too stressful. I mean, I was here when AIDS hit and we didn't understand what it was. The first thing that happened to us was we lost our call rooms at San Francisco General because all of a sudden that wing of the hospital where we slept was now full of young men that were dying. So there will be challenges throughout your career. We've just come through a pandemic that was a great challenge that discouraged a lot of young residents from going into emergency medicine. And I know caused a lot of nurses to retire just because the stress of that was so much to deal with. So you'll have challenges throughout your career, but you know, your foundation is you've got a great education, you love what you do, you like seeing your patients, and you like the surgery. That's the recipe for a happy professional life. So again, I really thank you guys for this opportunity. And like I said, I sat in those chairs before, and it's nice to be here and see the young faces. And please come up to me at the AUA and say hello.